All right, it's 11 o'clock. Hello and good morning, everyone. Welcome to our Project Echo telemedicine Project Echo. And our topic today is very important. It's your role in accessible telehealth. And I would like to thank Laura Lappy, our Project Echo manager, as well as Max Richards for helping us set up this educational session. Joining me today is my colleague, Dr. Sherry Sansibrian. She's the Associate Chair of the Department of Speech, Language, and Hearing Sciences of Texas Tech University Health Sciences Center, School of Health Professions. But before we proceed, I would just like to do a quick acknowledgement. This week, by the way, is Telehealth Awareness Week, and TexLa and the National Consortium are a proud supporter of the Telehealth Awareness Week. Next slide, please. We would like to thank HRSA as well as the Well Ahead Louisiana. This is a educational session funded by the HRSA of the Department of Health and Human Services. Next slide. We'd just like to mention that TexLa is a proud member of the National Consortium of Telehealth Resource Centers. Next slide. And so we are honored today with Ms. Lisa Bothwell. And just before we proceed, next slide. These are just some of the helpful tips for our Zoom meeting. Make sure everyone is muted and use the chat box liberally if you have any questions. Next slide, Laura. There you go. And I would like to pass the baton to Dr. Sansibrian.
Good morning. I'm happy to introduce our speaker today, Lisa Bothwell. Lisa's a program analyst in the Office of Policy Analysis and Development at the Administration for Community Living. She provides recommendations on and develops health policies that promote independent living and incorporate disability rights and the rights of older adults based on feedback from the Aging and Disability Networks, congressional reports, statutes, health studies, legislation, and other supporting data and materials. Her areas of focus include telehealth, 1115 Medicaid waivers, effective communication, and assistive technology. Prior to ACL, Lisa worked as a disability integration advisor in several different divisions of FEMA over the course of 6 years, deploying to more than 15 disasters. And prior to joining the federal government, Lisa was a student attorney in law school, focusing on the Fair Housing Act conciliations and landlord-tenant racial and disability discrimination cases. Lisa also has experience working for several nonprofit organizations, including the Louisiana Protection and Advocacy Agency and TDI. Lisa holds a Juris Doctor with a civil law certificate from Loyola University in New Orleans and a BA in mass communications from right here in Texas, from Texas State University at San Marcos. Welcome, Lisa. We're excited to hear what you have to share with us today.
Thank you so much. I appreciate it. Yes, I'm Lisa. It's nice to be with you today, and I'm honored to speak on this topic. For the last year and a half, it's been a very stressful period for the healthcare and providers. So it's an honor to be speaking with you today for telehealth accessibility for people with disabilities. Thank you for your time. I'm also honored because I am from Texas originally, born and raised in Austin. So I'm happy to be chatting with you all today. Next slide, please.
Next slide.
Great. So first off, I'll just talk a little bit about my agency. It is the Administration for Community Living. And ACL is an operating division under the U.S. Department of Health and Human Services. It was created around the fundamental principle that all people, regardless of age or disability, should be able to live where they choose, with the people they choose, and fully participate in their communities. So that was just a little bit more of an explanation. I won't read the whole slide, but next slide, please. ACL is supported by a range of laws, including the Older Americans Act, the Developmental Disabilities Act, and the Rehabilitation Act. Our work involves executing grants and programs to achieve these directives. And a lot of our funding goes to nonprofits and research in the area of disability and aging. One thing I like about my job is that we work with so many nonprofit organizations who specialize with people with disabilities, older adults, and they're run by and for these individuals. So I feel like there's a lot of connection to the community in that way. So I think it's a good opportunity to apply what we've learned from the community to really influence our policies and regulations. I will briefly mention the assistive technology grants, the different states and territories, the kind of funding that support the states, in an effort to improve the provision of assistive technology for individuals with disabilities. And this ranges for all kinds of ages and state programs. And when I was younger, I was actually able to use some of these programs because I lived in Texas. And, you know, I've come full circle, I think, at this point in my career. So the program for consumer response is, you know, during the COVID pandemic, we've had to be very creative with some of these things. Montana, Utah, the equipment that they used during the COVID pandemic, we've learned a lot from. The Economic Securities Act, the CARES Act, and additional equipment that has been loaned out to people. And equipment such as hotspots and various assistive technologies and programs that have been utilized for older adults using the telehealth technology. Illinois State also included putting together some telehealth assistive technology bundles. So some examples of this telehealth, including some of the assistive technology like screen readers, joysticks, large print, large keyboards, speech synthesizers. So if you'd like to learn more about this kind of program, you can visit the AT3center.net. I can also show that at the end as a link in the presentation. Next slide, please. So first off, I'll give some legal background for the accessibility laws. Next slide. The main federal civil rights laws I'm talking about today include the Americans with Disabilities Act of 1990. Oh, good. I see Sherry posted that at3center.net. Thank you for that link. So the ADA of 1990, we also are impacted by Section 504 of the Rehabilitation Act, Section 5057 of the Affordable Care Act of 2010, and other implementing regulations. These laws generally state that qualified individuals with disabilities may not be excluded from participation in, denied the benefits of the services, programs, or activities, or subject to discrimination by covered entities. Specifically, covered entities may not provide individuals with disabilities with an aid, benefit, or service that is not as effective in affording equal opportunity to obtain the same result, to gain the same benefit, or to reach the same level of achievement as that provided to others. There's some exceptions, of course, to this rule, including the undue administration of financial burden. If there's any fundamental alterations needed to the program, even if those two are exceptions and they might apply, there is still a requirement to take action to maximize the accessibility that is possible so that we can gain equitable service and accessibility. Next slide. So this slide is speaking to covered entities for these statutes. The ADA covers the activities of public entities or state and local governments, as well as places of public accommodation or commercial facilities. So professional offices of healthcare providers, hospitals, social service centers, insurance offices, and pharmacies. Those are kind of the entities that are covered. Section 504 of the Rehab Act applies to the activities of federal agencies and also applies to entities receiving federal financial assistance. Of course, that can include Medicare and Medicaid reimbursements. Section 1557 of the Patient Protection and Affordable Care Act applies to any health program or activity, any part of which is receiving federal financial assistance or under any program or activity that is administered any entity established under the Title I of the Affordable Care Act. And of course, its amendments, including the health insurance marketplace. Sometimes you might see some local or state requirements as well, which I just saw a bill that came up in New Jersey. It's not passed yet, but it does include specific language for accessible communication as relates to telehealth. Next slide, please. So for effective communication, covered entities must ensure those people with disabilities have effective communication like anybody else, which includes family members, companions, friends, or associates of a person that are seeking or receiving in any entity's goods or services. Next slide, please. To achieve effective communication, it might require the provision of an auxiliary aid and services. So covered entities must provide those auxiliary aids and services at no charge. And there are different kinds of auxiliary aids and services that you might see out there: qualified sign language interpreters, readers, speech-to-speech transliterators or translators, providing captions and other accessibility features for electronic documents or electronic information technology. So I mentioned earlier assistive technology. that people use. So those have to be accommodated within the programs as well. Auxiliary aids and services, can provide, and it really just depends on the method of communication that a user prefers, and that's at an individual basis. Because we're talking about complex information and content, we want to make sure that that is happening, that accessibility is there. In terms of the ADA, it has specific requirements for what we call VRI, video remote interpreting. And specifically about having to be clear. And there have to be clear performance standards. Clarity, the sound has to be good. There has to be the practices of the professionals involved. A lot of this hasn't been applied to telehealth yet, but it's being applied for the purposes of telehealth. Next slide, please. So this is especially important when medical situations are involved. Qualified interpreters, that means somebody who can effectively interpret accurately, impartially, both expressively and receptively. And because we're talking about specialized vocabulary in the medical world, so there's a lot of jargon that's involved, and one must be qualified in that regard. It's crucial to find qualified interpreters that can achieve effective communication for these contexts. And I'm struggling signing it because effective and effective communication is all the same sign. Also, for qualified speech-to-speech transliteration too, those people must be qualified as well. Somebody has to be trained to clearly understand somebody's speech disabilities and to be able to reiterate very clearly. Only in very limited circumstances can other adults or non-professionals interpret. And all of that is outlined in the ADA, but there's some more information on the links that will be provided. But it's especially important when we're talking about children interpreting. These people can't, children, non-professionals sometimes don't know the jargon or the information, cannot remain impartial. So we refrain from using children to interpret. Applies to adults too. There are several issues right now. We're looking at what's going on. Well, if you look at Britney Spears' example, having a caretaker, somebody with the person, their proxy. Let me think how I want to state this. There might not be the best interests. This person might not have the best interests of the patient in mind, so that's why the impartiality is very important. Yes. Next slide, please. Electronic information technology. There are guidelines from HHS, from the Office of Civil Rights, specifically pertaining to electronic information. EIT, can include your web pages, your websites. It could be electronic health records and documents. It talks about applying to different principles of those systems that house those kinds of information. Next slide, please. So I really like this quote. It's from 1990. When the ADA was actually signed and passed. Even though we are moving along we're rapidly developing our technology and really looking at accessibility. It's new to us and we're moving forward. But the intent behind the ADA mentions that we should grow with the evolving technology. The accessibility should grow and evolve along with our technology. Next slide, please. Sorry, the interpreter didn't know if we were progressing or not. So accessible telehealth, we need to invest in your practice using in telehealth platforms. We need to make sure that there's an ability to add a third person, such as an interpreter, ability to add remote care providers or captions. And consider reasonable accommodations too before the telehealth appointment. Give time so that the person, if they have any kind of sighted disabilities, that they have some assistance to use and navigate the platform. Next slide, please. So the Department of Justice has a hotline for people who have some general questions about the American with Disabilities Act. I might not be able to answer some of those questions today, but if there are some legal or financial questions, you can find some of this at the ADA website here cited, as well as the hotline that can be utilized. Next slide, please. Just checking out the time here. For research purposes, there's a lot of research out there. I would say that even though I'm posting some of this and sharing some of this research, this is not sponsored by my agency. It's research that we have collected. Next slide, please. So there's research papers speaking of telehealth unreadiness. And this is based on people having difficulty hearing, cannot use the phone normally, even with auxiliary aids. Sometimes people can't speak or make themselves intelligible or understandable. People that have dementia, people have vision problems, people that need screen readers or can't read print. Some people have no internet accessibility or might be not aware of how to use the technology. And some that have not used text or email within the past month. It was and there were 72% of these adults and 44% of people ages 75 to 84 that are not telehealth ready, as the stats say. So between 65 and ages 74, there is significant unreadiness there as well. Next slide, please. So last year, I think, was the last, it was December 2020. People with Medicare benefits and severe disabilities before the age of 65, we have some of these stats here, about 20%, 27% of those using telehealth services are Medicare beneficiaries. Next slide, please. So this is specific for people who have low vision or people who are blind. They did a study and a survey last year for almost 1,000 people. And there's about 30% of those reported meeting with their healthcare provider and using telehealth visits. And out of that 30%, 21% reported that the platform was not accessible. Next slide. So this research is something that I personally like. It's not really from ACL per se, but from my vantage point. Just some good ideas and some thoughts that we have encountered for accessibility in telehealth. So I added some thoughts on these next 3 slides. So compatibility with external devices or aids, accessibility features that are native to all operating systems. Those are good practices. Remember in the presentation, I talked about the accessibility of the assistive technology. And ACL provides funding for that kind of thing as well. So screen readers that are used to enlarge the screen that might make the platform more accessible. Make sure that things are intuitive so that people easily understand the platform, easily understand the icons, the texts, and how to navigate the system. And I used to work in emergency management. So it's almost, when you're thinking about iconography and how that communicates to a wide audience, these are interesting principles to include for accessibility with people with disabilities. Because in general, people that have a limited English proficiency could benefit from this. Also, multiple modes of communication would allow patients to select modes that are best fit for them. For example, somebody with that is blind or low vision, they might have difficulty using the computer screen, and they might use verbal messages to control things. People that are deaf prefer maybe to type in their messages instead of using their voice. And this is, of course, through WCAG content accessibility guidelines. So there are several federal laws that talk about the WCAG, the WCAG, and AAA guidelines. AAA is at a little bit of a higher or more broad level when talking about regulations, but there are some guidelines from WCAG, I think it's to WCAG 2.1. And 2.1 was developed after the dissemination of mobile equipment and mobile apps. Yes. Sorry, the interpreter stumbled there for a minute. So WCAG 2.1 is on the website. The guidelines are there. If you meet 2.1, you'll meet the 2.0 as well, those guidelines. And that of course, refers to web contents, your web pages, your web and mobile apps, including texts, images, audio visuals, and any structures therein. Next slide. I think we got that one. Consistently implemented standards and plugins should be provided to enable sign language or the appropriate interpretation within the same visual screen, right? to provide those services. And one thing that the reason why you want to have everything within the same screen, one reason, of course, is bandwidth considerations. And also the person might not have many devices. We can't assume that they have multiple devices for multiple screens. We don't want people to have to use a tablet and a desktop, for example. So we want everything within the same solution. And I do see some challenges with scheduling appointments. There are some apps and software out there that you use your phone to dial in for healthcare providers, and how we navigate those apps to include captions, interpreting can be quite difficult. Because some software, you click a button and you're instantly connected to a healthcare provider. So I know these kinds of systems have been brought up multiple times. There are so many best practices too for user-centered design to reduce overall physical and cognitive burden. So some of these, for example, include the widgets or unnecessary things within the platform. If somebody is older, maybe they're not quite used to certain kinds of computer platforms or computers in general, or if you have to tab or anything like that, different kinds of features within the system on a computer, people might not be too familiar with that. And some people might not be able to navigate very easily. And some people might not have the dexterity to be able to do that. And of course, the last is to be able to receive all communications in plain language. Things that are written clearly, that are organized, and that follow, other best practices for this specific audience, which means minimizing jargon, using the active voice, using everyday common words and vocabulary. Next slide, please. The one thing that comes up often is third parties, being able to pull in that third party, like interpreters or support services, and captioners. I hadn't seen this before, but it's a good point. Some people like to bring in other family members or interested parties by proxy. So that's a good design consideration overall, is to be able to include these people. And reviewing this article can help tie in some previous research that had been done pre-pandemic, but now it's starting to apply during and post-pandemic for telehealth reasons. So all of this is coming up. I thought this was a very unique article. Next slide. I think that's at the end of the slides. Okay. Some questions that have been asked to me. There was one question the other day. Was a question about if a healthcare provider wants to make sure that their telehealth platform is accessible for people with disabilities and older adults. What do I do? Who do I speak with? How do I engage with the community? So I thought this was a good question, because within the disability rights movement, you will often hear that nothing about us without us, that famous quote. So we need to talk a lot more about that. Some ideas that we have had is that there are several healthcare organizations out there involving emergency management. So, those groups are great to work with, those organizations, nonprofit individuals for disabilities and older people with disabilities and older adults, those various groups, and as well as incorporating users to test on your platform and to help by way of being involved in the design process of those platforms. I also would say that let me back up. Finding more information, I'll send it in the chat, but ACL also has something called the Elder Care Locator. And you can find local nonprofit organizations through that. They're ACL funded through different legislative funding streams. So, and many are led by those people with disabilities or those that are older adults. And they're the voice for those groups. So I will go ahead and chat that link too, so you can peruse that and find that locator to find those organizations that might give you some feedback. And that's really key, to incorporate those voices within your processes. I remember what I was going to say. For care providers as well, in the process of when you're thinking about how to navigate your process, sometimes the time it takes from getting an appointment, making an appointment, seeing a provider, the whole process from A to Z, and each and every step should be made as accessible as possible. And that's the accessible working process that I wanted to mention. So we're thinking about effective communication all the way through, accessibility on electronic information. So holistically thinking of all of this as something we need to work through and make accessible to get patients with disabilities or older adults the services that they need. Again, from step one all the way to the last step. And I think I made good time. I think it's okay to go ahead and close the formal presentation. So I guess I can open it up for any additional questions.
Well, Lisa, thank you very much for this wonderful presentation. And I would like to thank David and Becky, for helping us with the interpretation and everything. I'm actually reading a CDC, Dr. Sansibrian, recently, and I'm just astonished by the number. Like 61 million adults in the United States have disabilities, and one of the data that I look into is 1 out of 3 adults with disabilities 18 to 44 do not have usual healthcare providers. And I think we're disenfranchising a huge population of patients. And during my training, no one told me how to communicate, with people with disabilities. I was not, I just learned how to do some, basic sign language, and the hospital assigned you a, American Sign Language interpreter. But I'm not quite sure if we're doing enough. Are we doing enough? What are the other things that we could do as a provider, as a professional, as a healthcare worker, and as an institution?
Do you want me to answer that or comment on that?
Yes, please.
let's see. I mean, I agree. I would like to see several things happen within the healthcare, in the healthcare world. I would love to see more statistical evidence-based information that we get from accessible telehealth. This is a hot topic, of course, for audiology and telehealth. And of course, a lot of providers out there, there's a lot of evidence that says we shouldn't use auditory telehealth with people with disabilities or older adults from that perspective. It's not going to be perfect. It's not a perfect solution. People have found that. It is a necessary part of using telehealth. We need some more evidence-based research on this. We need some more data about the accessibility part of sort of the audio only. It's very difficult to find articles on this kind of information. And there's some more than I talked about today, but there's not a ton out there. Also, something I would like to see more of, as you mentioned, education. I mean, I appreciate that you brought that up. I would love to see more education within the medical field about how to work with people with disabilities. That's nursing school, medical school, or various other healthcare degrees.
Dr. Sansibrian, by the way, is the Associate Dean of Department of Speech and Language and Hearing Sciences of Texas Tech. So, Dr. Sansibrian.
So I'm a speech language pathologist by training, and our department has both speech and audiology. And we have been offering our services by telehealth for about 7 years. So COVID was a surprise to everybody, but we felt very lucky that we were able to transfer our services from face-to-face to telehealth in about a week's time, a year and a half ago. And most of our patients were able to participate. Sometimes we have the combination of quite elderly folks who attend our stroke group. And of course, they have hearing impairment. And of course, they live in a rural area. So all the factors. But I've been pleasantly surprised what a large percentage of them are still able to participate in the services that we offer by telehealth. So we offer a hybrid group every Tuesday morning for people who've had strokes and their caregivers. Some are here on the campus in our building, in our clinic, and the others are scattered all over. So, and then I see school-age children. Right now I'm treating a middle schooler with hearing loss who lives about 90 miles from the Health Sciences Center. So coming in weekly for services just would not be effective. But this works great. 6:15 every Wednesday evening. She gets her therapy from her home while I'm providing those services here. And then we're also able now to provide services through our project with Monfort, with the Texas Department of Criminal Justice. So if those patients are not able to come to our clinic or we're not able to enter their unit, we can use telehealth. So we're getting better at it. We know we have lots to learn. And I'm most proud that we're training a generation of students to do this and do it as well as we know how today, which hopefully will be better each year as we teach it. And they'll go out much more prepared to practice this way than I and my colleagues ever could have been.
Absolutely. It's great to see. You know, now we're talking a lot about, in my office and all over the federal government, I think we're talking about the executive order on equality. So it's definitely something that we are looking forward to in our future. You know, how will all of this impact our future learning and our professional growth?
True. We just hope that we learn more every year as we get better at this, and it
Mhm.
becomes something we do every day. I expect to see that we will do a better job of it, but for now, we're still learning lots.
Absolutely. I agree. Same here, learning a lot.
I'm actually, amazed on, the things you're doing, Dr. Sanstibrian, on, taking care of our patients. And I wish we could give them all the gadgets
I
necessary,
know.
the cart and everything that could make the telehealth experience better.
Mhm.
But my thinking though is, just like doing the Zoom, right? Sometimes your bandwidth is not enough that you had to remove the video. So
That's
how are we
right.
dealing with those,
Oh.
broadband problems?
It's been such an issue. The families who live in the country are very dedicated. And I've had the child that I see every week, that family has actually driven that child up into town, which is a very small town, just to get better access, because at home, all of a sudden the Wi-Fi was not going to support what we needed. And the same has been true for some of our elders, especially if they live in a long-term care facility. Sometimes they don't have the bandwidth, or there's one computer that is shared by a whole lot of residents. So those are problems that I wish we could provide more of the hardware in these places, or that hardware became a standard that everybody, yeah.
Absolutely.
And the Health Sciences Center did some amazing work providing hotspots for patients and students. And that's been a lot of help for people who are in extremely rural areas to have that ability. So we appreciate that support, but
Mhm.
we hope that it gets better too, so that when
Absolutely.
you live in tiny town West Texas, you can still access services just as easily as if you live, down the road from the Health Sciences Center.
Absolutely. And I think what we're, mentioning sometimes is just like a hack, in order to get a better broadband, we sometimes tell them, hey, go to a library,
Right.
go to, this is not promotion at Taco Bell, where you could have a free Wi-Fi.
Right.
I think that is very necessary as well.
Mhm. And we've had families who are more than willing to do that. So they value the service enough that one family drove 20 miles to get to someplace where they could access the internet, but it was better than driving 100 miles to come to the Health Sciences Center.
Absolutely.
So
Absolutely.
I think families are meeting us more than halfway. I just hope that sometime it will be equally convenient for everybody. We want accessibility to be fair to everyone. But when we add in the rural factors along with disability factors and sometimes age factors, it is difficult to meet.
It is double, triple whammy, right?
Absolutely. It
Mhm.
grows exponentially. And so we absolutely try to do the best we can, but the reality is sometimes we fall short of perfect, for sure.
Absolutely. The other thing, though, is I don't know if JACO is doing this, but I think there should be some form of metrics, some form of checking the box that you're doing this. So I just want us to be more accountable on doing more.
Right.
So I'm hoping, this will be included in the metrics on, accreditation and whatnot, that we're offering this. By the way, thank you very much, Laura, for putting a closed captioning. This is the first time we put the closed captioning. I thought about it, and I kind of thought that we should be doing this all the time in all the webinars,
Right.
and there should be an option on making it bigger if you have some, vision problem
Right.
as well.
Yes, and that's something I think everyone has just started to do now that Zoom has made that easy for us. And that's been a big help for many people that we wouldn't have even thought had a need or had a disability. It's surprising how many people benefit from the same things that help our patients with disabilities. Those same things can help so many people that it's not really asking that we do this extra just for this unique population. It's something that lots of people can benefit from. And if people understood that, maybe they'd be a little more willing to pay for it and to support it and use it.
Lisa, I have a question. Is this, extra things, that people with disability really needs? Is this being paid for by insurance or Medicare? I'm not quite sure.
Yeah, this is Lisa. I'm not an expert within the Medicare area. I'm still learning quite a lot of that because I started a couple of years ago in HHS. I'm happy to ask some of my colleagues. And one thing that I was going to say is that people with disabilities and people even without disabilities benefit from captions. We were talking about the captions.
Mhm.
You know, people that are starting to learn English, people that are younger, people with limited English proficiency. That's one thing. I need to find an article that I had come across that takes somebody like 7 years before they admit to needing a hearing aid and going to get a hearing aid. So the hearing loss journey. So it takes a long time for somebody to accept that. Yeah. So I think captioning again benefits us all for many groups of individuals.
All right. Do we
Now,
have any
I was
questions?
gonna say one other thing. I can't remember. Oh, I saw one question. Oh, I know of one. Laura's question, I believe. One thing we mentioned was mobile hotspots. And I'm not sure what Texas does in terms of assistive technology and telehealth, but reaching out to that program, the assistive technology program, and see what they do, what other states have done for their assistive technology programs in purchasing different equipment like hotspots to provide to people with disabilities or people who need it that are using telehealth. So I would suggest starting there too, because they're experts in that arena, and they might have several other resources that might be helpful to you, like broadband issues for rural areas. There's probably some resources out there. And I think, Laura, you also mentioned for the health center there in Texas, patients who are deaf and hard of hearing, they report having issues with ASL interpreters or getting accessibility for personal appointments, I believe. Is that, if I'm reading that right? Any best practices? Oh, hang on. Sorry, I'm just reading through your question right now. Sorry, this is Lisa. I didn't think about this issue, haven't encountered it before. I'm just trying to think. It would definitely depend on the platform specifically, but I don't have enough information right now to give you anything on like which platforms there are that are being used. I would be curious if this health center has already reached out to the platform developers and getting some of those questions answered. I think that would be my question. I don't know which platform it is being used. So
I think that's a good point. Sometimes you just have to talk to the developer. It's just like our EMR. You just have to, tell them, hey, we need this and we need that. Sometimes they will not give you the everything, all the gadgets necessary. But if you will talk to them, sometimes, Laura, they could be able to develop that. By the way, a lot of people using Zoom. We use
Right.
Zoom, and it helps us a lot. And I didn't know this. That you could just do yourself if you're a host, do the closed captioning. It costs you nothing.
Right.
And so is one of the Zoom hack I'm telling you right now. You could use Zoom, and most of it are HIPAA compliant. Actually.
Yes. So if you have your BAA in place, then you're HIPAA compliant. Works well, and it seems easy for most of our patients to use. So it works for us.
Absolutely. Any other questions from the group? This is wonderful, by the way.
This is Lisa. I would add to that as well. I know it's very important. I wouldn't say that captioning is always the solution too. There are some articles and research out there that talks about telehealth accuracy of automatic captions.
True.
Wish I had the statistics ready off the top of my head. I have them somewhere in my notes on my computer, but I know that with trauma, I know some of the inaccuracies are made worse. So it's important that we're able to provide auxiliary aids and services that are absolutely effective. So it's always something important to keep in mind. Some people don't have a lot of experience with Zoom auto captions, but I know that, there are some frustrations out there that, the terms, sometimes they don't have punctuation or accurate grammar. So it can completely change the meaning of a sentence. So one has to be savvy about doing that. And we have to test some of these things. In my own workplace, I've been playing around with it, trying to make it work. And there's a challenge that, we were talking about Medicare in one meeting, and it's a very important topic, obviously, but the captions said, had a negation or something like that. And then what was said, there was a negation, but the captions didn't include the negation. So I thought it was an affirmative. So when we were talking about legal requirements. So again, auto captions can lead to some really big misinterpretations.
And as a provider, I've had to learn to speak more slowly when I'm using auto captioning. It seems to do a better job. I normally speak pretty quickly, and the captioning system can't quite keep up, and there are more errors. So it helps for providers to practice as well and improve the accuracy.
Absolutely.
That's true. So I think we learn a lot, for people with disability, at the same time for provider as well. I am guilty of that. I have problem with, with my speech, the speed. I'm usually on the go fast mode all the time. And so it is a good practice to sometimes be slow, make sure you project, make sure you pronounce well. And for me, English is not my first language. So, I still had to learn. And this is a good learning experience for us. If there's no more question, I would like to remind everyone to make sure they complete their session evaluation. You could go to this link, or you could get your phone and click on the QR code noted in your screen.
And we'll make sure to email this out right after the session, just so everybody has it.
Excellent. Thank you, Laura. Next slide, please.
Sorry.
So we would like to thank Lisa, David, and Becky as well. And Dr. Sansibrian, thank you very much. You guys will be receiving a challenge coin, as a token of our appreciation, for your help and service. And we will mail you, Lisa, to DC. I don't know what the address of David and Becky, but we will send you an email. And Dr. Sansibrian, this is your challenge coin. And next month, we will have a very important topic as well. It's about remote patient monitoring to be delivered by Novella Thompson, the director of the Population Center at University of Virginia on October 14, 2021. So Lisa, everyone, you are invited to attend our webinar on RPM, or remote patient monitoring. So again, thank you very much, guys. Thank you, Dr. Sansibrian. Thank you, Max and Laura.
Thank you.
Thank you again, Lisa.
No problem. Bye, everybody.
Bye-bye.
Could you do that?